Hello friends, in the previous class we have discussed about the pharmacotherapy of Parkinsonism 1. In this we have discussed about the basic pathophysiology of the Parkinsonism, possible target sites of the drugs used for the treatment of Parkinsonism and pharmacology of levodopa and levodopa-carbidopa combination in detail. In this class, we will discuss pharmacological basis, therapeutic uses and we can say therapeutic status as well as the adverse effects of MAO-B inhibitors, COMT inhibitors, dopaminergic agonists, dopamine facilitator and centrally acting anticholinergic agents in the treatment of Parkinsonism. And in the last we will discuss about the pharmacological principles for the management of Parkinsonism. Before going ahead, let us summarize the previous lecture in nutshell in this slide. We all know that dopamine cannot cross the blood-brain barrier, and that is why we are using levodopa which can cross the blood-brain barrier, and after entering into the brain, it is converted into the dopamine with the help of dopamine decarboxylase enzyme. But the major problem with the levodopa is its peripheral degradation with the extracerebral dopa decarboxylase enzyme into the dopamine, which is responsible for majority of the adverse effects. And this problem can be overcome with the use of carbidopa. And that's why levodopa-carbidopa combination is used in the treatment of Parkinsonism. Same way in the brain, in the periphery also, levodopa is metabolized by catecholomethyltransferase enzyme into 3-O-methyl-dopa. So, the another target site for the drug is catecholomethyltransferase COMT inhibitors. These are tolcapone and entacapone. Another target site is MAO-B inhibitor. These are selegiline and racegiline. Then the drugs that are directly acting on the dopaminergic receptors, non-selective ones are bromocriptine and selective ones are ropinirole and pramipexole. Then the drugs act by hastening the presynaptic synthesis and release of dopamine, that is amantadine. And lastly, centrally acting anticholinergic agent, that is trihexyphenidyl hydrochloride. Now we start with our first drug group, that is MAO-B inhibitors. There are two types of the MAO enzyme, MAO-A and MAO-B. Now this monoamine oxidase MAO-A enzyme, it is having a wider distribution in the peripheral adrenergic nervous system. In the CNS also it is present, and it is also present in the intestinal mucosa. While the MAO-B enzyme, it is having a selective distribution mainly into the CSM. Again in the CNS, it is present into the corpus striatum and some amount in the platelets. Now adrenaline, noradrenaline, dopamine, all these catecholamines as well as 5-hydroxytryptamine, these are metabolized exclusively by MAO-A, and that's why MAO-A inhibitor can be used in the treatment of depression in which the level of the serotonin is reduced, and by inhibiting the MAO-A we can increase the level of serotonin. But at the same time, MAO-A inhibitor increases the level of noradrenaline, adrenaline, and it will lead to hypertensive crisis. But again come back to our point, MAO-B, it is principally responsible for the degradation of dopamine in the brain, and that's why its selective inhibitor selegiline and racegiline increases the level of dopamine in the brain, and these drugs can be used in the treatment of Parkinsonism. First about the selegiline. Now As like the other drugs, low dose selegiline only acts as a selective inhibitor of the MAO-B enzyme, that is 10 milligram per day. Now what is the therapeutic status of selegiline in Parkinsonism? It is useful as a monotherapy in the early stage, as well as it can also be useful along with levodopa carbidopa. And with the levodopa carbidopa, it enhances the effectiveness of levodopa. It reduces the required dose of the levodopa and hence the side effects of the levodopa. And the biggest advantage of MAO-B inhibitor is, we all know that even though the levodopa is the principal drug for the treatment of the Parkinsonism, but it is also responsible for hastening the progression of the disease by its metabolic products. Now, selegiline, by inhibiting the metabolic degradation of the dopamine, it is having a neuroprotective effect. Now, what are the limitations of the selegiline? Okay. In advanced cases of the Parkinsonism, whenever there is a significant on-off effects, selegiline is not that much effective, and peak dose related side effects of the levodopa, which is its major limitations, dyskinesias, confusions and hallucinations, it may be worsened because we are inhibiting the metabolic degradation of the dopamine, and hence the central level of the dopamine is increased, and that's why these side effects can be increased. And another major limitation is, even though it is having many advantage and neuroprotective effect, but effectiveness of the selegiline in Parkinsonism is a very short-lived. It lasts for 6 to 26 months. Now, adverse effects. As I have told that increased level of the dopamine because of the inhibition of MAO-B, the central dopaminergic adverse effects, postural hypotension, confusion, psychosis, all these will be increased. And if we use selegiline in a high dose, then its selectivity will be lost, and there can be chances of hypertensive interactions with indirectly acting sympathomimetic agents. Now, the another problem with the selegiline is its conversion into the amphetamine, and we all know that this amphetamine, it causes restlessness and increased anxiety, which may lead to insomnia, and that's why even if we use the selegiline, it is given, one is in the breakfast and one in the lunch, but it is not given at the bedtime. And because of this, selegiline is contraindicated in patients having history of convulsions. Now, resegiline. My dear friends, always remember that the Me Too drugs, it means that the drugs belongs to the same class. The newer drugs that are more potent, that are having longer duration of action, and some selective specific action that is having lesser adverse effects. Same thing applies to the resegiline. It is 5 times more potent than selegiline. It is longer acting, and it is not metabolized to the amphetamine, and that's why restlessness, anxiety, insomnia, it is not seen with the resegiline, and the dose is 1 milligram OD in the morning. Now, the next drug group is COMT inhibitors, and these are entacapone and tolcapone. Now, look at the slide. Both centrally and peripherally, dopamine is metabolized by catecholomethyltransferase into 3-O-methyl-dopa. Now, if we inhibit this catecholomethyltransferase enzyme in the brain, obviously the level of the dopamine is obviously the level of the dopamine in the brain is increased. But now, how this peripheral degradation of the levodopa by COMT, if it is inhibited, then how it is beneficial in the treatment of Parkinsonism? My dear friend, understand that If the levodopa is not metabolized by COMT, then the amount of the levodopa entered into the brain will be more. So the more levodopa is available for the conversion into the dopamine, and hence the level of the dopamine in the brain is increased. And that's why both central and the peripheral inhibitor of COMT is helpful in the treatment of Parkinsonism. We are having two drugs. One is the tolcapone and another is entacapone. Tolcapone, it is an COMT inhibitor both centrally as well as the peripherally, while entacapone is the only peripheral inhibitor of COMT. Now, some common features of both of these two drugs. These are selective, potent, reversible COMT inhibitors. The therapeutic status, they are used as an adjuvant to the levodopa carbidopa in advanced cases. How they are helpful? To smoothen the wearing off effect, increases the on time and decreases the off time. We all know that in the advanced cases of the Parkinsonism, after 2 to 5 years of the levodopa therapy, there is an end of dose deteriorating effect or wearing off effect, followed by on-off phenomena, and that shows the progression of the disease and the striatal neuronal degeneration. Now in this case, if we add this COMT inhibitor, we can either decreases the intensity of these adverse effects, or we can prolong the on time and decreases the off time. And because of this advantage, it increases the activity of daily living. And by doing this, we can somehow reduces the dose of the levodopa, and the levodopa dose related side effects, it can be minimized. Now, what are the adverse drug reactions of COMT inhibitor? Same way that all the central adverse effect of the dopamine, it can be worsened. Mainly the dyskinesia, postural hypotension, hallucination, all these adverse effects are worsened. Now there is a one specific side effect, diarrhea. It can be seen with entacapone as well as yellowish orange discoloration of the urine. Now there is a one specific side effect of the tolcapone. You have to remember this. Tolcapone can cause acute fatal hepatitis and rhabdomyolysis, and that's why tolcapone is banned in various countries also. So you have to remember like this, tolcapone, even though it is a both central as well as the peripheral COMT inhibitor, and that's why it can be more effective than the entacapone, but you just remember Toltex. It means that Toltex, tolcapone. Tolcapone is having these adverse effects, and that's why tolcapone is banned in various countries also. The dose of the entacapone is 200 mg with each dose of levodopa. Now the next drug group is dopaminergic agonist. These are divided into the two types, ergot alkaloids. Again, in the ergot alkaloids, there are selective and non-selective agents, bromocriptine, pergolide, lyseride and cabergoline. These are the non-selective agents. And non-ergot alkaloids, these are selective agents, ropinirole and pramipexole. These are ropinirole and pramipexole. I have showed in the green because these are used nowadays. They have superseded the use of the bromocriptine in the Parkinsonism. Now, first and foremost, what are the advantages of this dopaminergic agonist? We all know that dopaminergic agonists directly act on the dopaminergic receptor in the corpus striatum, and this mechanism is responsible for its pharmacological action. But what are their advantages over levodopa carbidopa? First and foremost is they not depend on the functional integrity of the striatum. This is very important because in the Parkinsonism already there is a neuronal degeneration, and in the advanced cases the degeneration is even more, and that's why in the advanced cases the levodopa is not effective because functional integrity of the dopaminergic neuron is essential for the function of levodopa. Now here these agents they directly act on the dopaminergic receptors, so no functional integrity of the striatum is required, and these agents they are not converted into the potentially toxic metabolites that are responsible for the progression of the disease. Like the levodopa, in the levodopa there is a competition with the other natural substance for the transport into the brain. Here there is no competition for the transport. These are the selective agents and they are longer acting. Many of these agents are given once daily and they are more effective in management because of the selective action, because of the longer duration of the action, because of the direct action of the dopaminergic receptors, more effective in the management of motor fluctuations, and because of this better control of on-off phenomena. So all these are the advantages of dopamine agonist. Now what is the therapeutic status of dopaminergic agonist? They can be used as a monotherapy as well as in combination with levodopa and carbidopa. As a monotherapy, they can be used in early and mild cases, especially in the younger individual, while in the combination therapy, the main purpose is to prolong, because we have discussed the effect of the levodopa, it lasts for 2 to 5 years. So if we add this drug group, we can prolong the effectiveness of levodopa and we can reduce the dose of the levodopa, and hence dose related side effect can be reduced. Now among the agents, first is the which was previously widely used, that is bromocriptine. It is a very potent D2 receptor agonist, but unfortunately partial agonist and antagonist on the D1 receptor also. The dose requirement for the monotherapy is very high, and in that dose it leads to intolerable side effects like vomiting, hallucinations, hypotension, nasal stuffiness and conjunctival injection. The dose ranges from 125 mg to 5 mg TDS, but as I have told that because of the availability of the selective longer acting D2 and D3 receptor agonist, now the bromocriptine is very rarely used for the treatment of Parkinsonism. Now we focus on the selective agents, ropinirole and pramipexole. These are the agents, dopaminergic agonists, which are used in the treatment of Parkinsonism. But what are their advantages over bromocriptine? They are selective agonist of D2, D3 receptor. They are better tolerated. They are longer acting and quick dose titration. This is very effective because in the bromocriptine, because of the significant adverse effect, the dose titration requires up to 1 to 2 months. While here the adverse effects are less, and that's why quick dose titration within 1 to 2 weeks it can be possible. Now what are the adverse effects? First and foremost is the nausea, hallucination, postural hypotension. All these adverse effects are the central dopaminergic adverse effects. Second is, this is a very peculiar adverse effects of the ropinirole and pramipexole. These are daytime sleepiness. Then important one is behavioral side effects, because again I am repeating that increased level of the dopamine in the brain is responsible for certain behavioral adverse effect and psychiatric adverse effect, and these dopaminergic agonists, they can lead to the behavioral side effects such as impulsive shopping, gambling, inappropriate sexual overactivity. So, the person who is having psychiatric history or tendency to having some psychiatric problem, this drug should be very cautiously used, or if possible not used. Now there is another therapeutic use of the ropinirole, and that is restless leg syndrome. We will discuss later about the restless leg syndrome, and the dose is 0.25 milligram TDS to 4 to 8 milligram TDS. Now pramipexole, it is somewhat more selective. As far as the receptor selectivity is concerned, it is more selective as compared to the ropinirole. Other points are similar to that of ropinirole. Now the next drug group, that is a dopamine facilitator. It is also a NMDA, N-methyl-D-aspartate or glutamate receptor antagonist, that is amantadine. Now this amantadine, it is a primarily antiviral agent used for the prophylaxis and treatment of the influenza A2. But serendipitously, it has been found to be effective in the treatment of Parkinsonism by promoting the presynaptic synthesis and release of dopamine in the brain. It is also having antagonistic action on the NMDA type of glutamate receptor. But my dear friends, this drug is very less effective as compared to levodopa carbidopa. Its efficacy is similar to that of anticholinergic agents. So what are its indications? It can be used in a very mild case, or it can be used very short term use with the supplement of levodopa carbidopa for the advanced cases to suppress the motor fluctuations or the abnormal movements. The side effects: insomnia, restlessness, confusion, anticholinergic effects, and that's why it is when we are combining these two drugs, amantadine with the centrally acting anticholinergic, then the chances of adverse effects and severity will be more. And there is one specific adverse effects, that is libido reticularis. It is due, but this is not that much clinically significant. As I have told, side effect increased when combined with anticholinergics, and the dose is 100 milligram twice a day. Then the next drug group is the anticholinergic agents. Now again we have to increase or we require an agent which is having a specific central action, because our aim is to control the excessive cholinergic overactivity in the brain. So the agents must have a higher central peripheral anticholinergic action ratio. You know that there are certain H1 antihistaminics, first generation. They are having a very high degree of anticholinergic agents like promethazine. They can also be used. But these anticholinergic agents, they are more effective in controlling the tremor, somewhat effective in controlling the rigidity, and negligible effect on the hypokinesia. As I have told, these agents act by reducing the unbalanced cholinergic overactivity in the striatum, and the degree of the improvement is very less. You can say that less than 25% of the improvement, and that also lasts for 4 to 8 hours after a single dose. Now, what are the advantages of centrally acting anticholinergic agents? First is, it is the only drug group effective in the drug-induced Parkinsonism. Now, what do you mean by drug-induced Parkinsonism? That if we are using any dopamine receptor blockers drugs, one thing we are using is in the treatment of psychosis, a D2 antagonist, and second, we are using the dopamine antagonist in the treatment of vomiting. Now, whenever there is a Parkinsonism effect with these drug groups, then centrally acting anticholinergic agents are the only agents that are effective. Now, this is a very commonly asked question, that why this is a drug of choice and why the levodopa-carbidopa combination or the other drugs are not effective. The reason is that in the drug-induced Parkinsonism, the dopaminergic receptors are already blocked. So that's why if you use levodopa or if you use any drug which inhibits the metabolism of the dopamine and increases the level of the dopamine, or you use any drugs which facilitate the release of the dopamine, these are not effective at all, and the reason is that the dopaminergic receptors are already blocked, and that's why the only thing that we can do is we can control the excessive cholinergic overactivity, and that's why the only effective drug group is centrally acting anticholinergic agents. Another advantage is very effective in controlling the tremor, and because of its anticholinergic effect, it is effective to manage the siluria, excessive salivation. And lastly, they are cheap, inexpensive. And if we compare the side effects, even though anticholinergic drugs, you have already learned anticholinergic agents, they are having many side effects, but the side effects that is due to the levodopa is much more. They are dose limiting as compared to the anticholinergic agents. Now what are the limitations? Degree of the effectiveness, it is a very less. Effective only in controlling the tremor, less effective in controlling the rigidity, and least with the bradykinesia. Impairment in the memory, cognitive function, organic confusion and blurred vision, and because of these anticholinergic side effects, they are poorly tolerated by elderly, especially the elderly male. We have to take care while prescribing the anticholinergic agents in these individuals, and as far as possible we have to avoid the use of centrally acting anticholinergics in the elderly individuals. Now, lastly, the certain management principles. Now, Parkinsonism is a progressive neuronal degeneration. So, the treatment will be last lifelong, and we require a multi-modality treatment approach. It includes non-pharmacological measures, pharmacological measures, as well as the surgical approach. In the non-pharmacological approach, education about the disease to the patient and his or her family members, emotional supports and psychological therapy, exercise and physical therapy, speech therapy for the dysarthria, and nutritional supports. But in this lecture, we will focus on the pharmacological principles for the management of Parkinsonism. Right from the first slide, I am telling that none of the drugs alter the basic pathophysiology of the disease. These drugs are having just a symptomatic improvement. So we have to initiate the therapy when symptoms are going to affecting the daily life of the individual. And initially in the mild case, one should start with a monotherapy, either with the selagelin or rasagelin or centrally acting anticholinergics. Now, when these drug groups are not effective, then one can use the combination of these drugs. Even if this drug's combination is not effective, then one can start using dopaminergic agonists like ropinirole and pramipexole, and finally in the management one has to start, when all other drugs fails, levodopa-carbidopa combination. And the reason is that, first reason is levodopa, the metabolism of the dopamine into the toxic metabolic products, it is responsible for the progression of the disease, that is one. And second, even if the levodopa-carbidopa therapy is effective, but this effectiveness start decreasing after 2 to 5 years. And that's why if we add the levodopa-carbidopa combination later in the therapy, we can delay the progression of the disease. And in the advanced cases, when the levodopa-carbidopa combination leads to certain adverse effects and this combination is not effective in controlling the disease, we can use either of these agents as an add-on therapy, either MAO-B inhibitor or the one dopaminergic agonist, selective dopaminergic agonist, or COMT inhibitor. So this is all about the pharmacological principle for the management of Parkinsonism. Thank you very much. If you are having any question, you can ask on my personal email ID that is mentioned on the first slide. If you like these slides, then please subscribe to my channel Pharmacology in a Simplified Way. If you are having any suggestions, feel free to ask.